So this is the Heent Pcl HM2 marker and HM2 cruise. So real quick, we're just going to run through the basic head, ears, eyes, nose, throat exam. Okay. So first thing you're going to do with all PCLs is going to be your VTEAM acronym. And that's standard practice whenever you come in, the vitals and everything else. Okay. So when you actually start the exam itself, you're going to start with the head. So with everything, you're always going to start with inspection. So there's 4 places that you're going to be quote-unquote inspecting for on the head. You're going to be inspecting the skull, the scalp, the head position, and also the facial features. Okay? So that's a real basic once-over. Is just make sure when you're doing the scalp, you're actually moving the hair and looking for anything as far as like lesions or anything like that. I know it's like palpating at the same time, but you're just inspecting. Then you roll into the palpation of the 5 areas. Okay? So the 5 areas are going to be the skull, you're going to palpate the scalp, okay, and then you're going to come down and you're going to palpate the temporal arteries. Real easy day, you can just place your hands. Next is going to be the temporal mandibular joint. You have the patient open and close their mouth a couple times. You're feeling for crepitus or any bony stuff like that. And then you're going to do the salivary glands, okay? So you have the parotid, which are behind the jawbone here, the mandible, the submandibular, obviously below the mandible, and then the sublingual, which is going to be here. And correct, and we're also going to be looking at the hair and palpating the hair for seeing if it's dry or oily or anything like that. Okay. After that, you're going to roll into your. You're going to be auscultating the temporal arteries for bruits, and you don't actually percuss the skull, so don't worry about that. It's on the PCL sheet, but just X it off. So yep, go ahead and just auscultate bilaterally. After that, that's the entire head. After that, you're going to roll into the neck. So again, you always start with inspection. So you're going to be inspecting the muscular symmetry. You're going to be looking for any abnormalities. You're going to be taking note of the anterior triangle and the posterior triangle for the landmarks, sternocleidomastoid, trachea, and the mandible. And then in the back, it's going to be the trapezius muscle, sternocleidomastoid, and the clavicle down here. Just making sure that everything's where it should be. You're also going to be looking for fullness at the base of the neck. You're going to be taking note if there's any carotid or carotid artery prominence or JVD, and you're going to also be looking at the trachea itself. I don't think I'm missing anything. Okay, cool. So after that, you're going to go into the palpation of the neck. So this is where you're actually going to be palpating the trachea, just making sure there's no, masses, nodules. And at this point, too, you can have the patient, you should have your glass of water here, have the patient take a sip of water, just making sure you get that good rise and fall. And then you're also going to be palpating the hyoid bone, which is at the very top of the trachea, the cricoid cartilage, the thyroid cartilage, the cricoid cartilage, and then you're also going to be taking note of any tracheal tugging. And that should be, and the lymph nodes, of course. Yeah, so what you're going to be doing with the lymph nodes is you can start in the back. So you have your occipital lymph nodes, okay, your posterior cervical chain lymph nodes, your post-auricular, your pre-auricular, remember they're always in the crevices, and then you have your parotid, same as your salivary gland, your tonsillar, submandibular, submental, anterior cervical chain, and then finally your supraclavicular, okay? After that, the next part of the neck you're going to look at is the actual thyroid itself. Okay, so the thyroid is just above the sternal notch. So if you locate the sternal notch, you just come up there and there's a nice smooth muscular area right there where there's no ridges of the trachea, and you're just going to go ahead and palpate that. While you're palpating it, you're looking for any nodules, enlargement, anything like that, and you're going to have the patient take another sip of water while you do it. Have them swallow. Good. After that, you're going to go ahead and displace the trachea, go in and one way. Have the patient go ahead and swallow, and you're going to be palpating on the opposite side for the thyroid because it sits behind the trachea. And then you're going to do the same thing for the other side, obviously displace, palpate, have the patient swallow, and that should be it. And then you're also going to be auscultating in the event that there's any enlargement of the thyroid, and that's something you could say verbally or actually do. Okay, so that's all of neck. So head and neck is done. You move on to the next one, which is the long one, which is the eye. So you start with your inspection of the eye, your external structures. So you're looking at the eyebrows, you're looking at the eyelids. Oh, I'm sorry. You start with the actual visual acuity. My bad. So you would say to the instructor, I'm going to go and do my Snellen chart, testing visual acuity, and then after that you're going to be doing your Rosenbaum or your Jaeger card, which is a near vision, and then lastly you're going to do what's called a confrontation test. So the patient's going to cover the same mirror image eye as you. So cover your eye, and then what you're going to do is you're going to come in from the periphery in 3 different areas and wiggle your fingers and ask the patient to see when they can see it. See it? Good. 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 Okay, and then you're going to do that bilaterally as well. Then you go ahead and you inspect the actual external structures of the eye. So eyebrows, eyelids, eyelashes, the orbital spaces, and you're just looking for any lesions, nodules, erythema, edema, anything like that that would be outside the norm. Now, on the PCL sheet, later on it talks about the lacrimal apparatus. I like doing it right now because I'm here. So palpate the lacrimal apparatus, which is up top above the eye, and then inside the eye, because obviously the lacrimal apparatus comes across and then into the nose. Okay. After that, you're going to be inspecting the conjunctiva, which is, you go ahead and just have the patient relax, and you can pull down their eyes, and you're just looking at the conjunctiva, looking for any signs of pterygium, any inflammation, anything like that. After that, you're going to look at the cornea. So you go ahead and take your, you can either take an otoscope or the ophthalmoscope, and you just go ahead and have the patient open their eye up, and you just go ahead and shine the light across it, and you're looking for the clarity of the cornea, making sure there's no cloudiness or anything abnormal in the cornea, and you would do that bilaterally as well. Then you're also going to basically verbalize that you would do the cotton wisp test, which is where you would be touching a piece of cotton against the cornea to elicit a blink. Next, we're going to be looking at the iris sclera and the iris sclera and lens for any abnormalities, anything, and that's just a simple observation of the eyes. So white part of the eye is the sclera, obviously iris, and then the lens. After that, you're going to go into the pupils. So you're going to take note of the size and shape of the pupils. Crew's got really dark eyes, so it's kind of hard to see, but you're going to take note of the size and shape of those. Then you're also going to do the reaction of the pupils to light. So it's easy to just use, again, the otoscope for this. And there's 3 or 4 types of tests. So the first one is going to be direct, which is I put the light in his eye and his pupil constricts. Okay. Consensual is I put the light in his eye and the opposite eye is going to constrict. Then I do the swinging light test, and I go from one eye to the next. So constriction, then it should dilate, and the other eye should be doing the exact same thing. Okay. And then the last one is accommodation. So you have the patient focus on a spot off on the wall, and then you hold your finger here, and you say, go ahead and focus on my finger, and then you observe their pupils for constriction as their gaze shifts to something closer. After that, this is also in the PCL where it talks about the lacrimal apparatus and all that other jazz. So if you do it earlier, it saves it from doing it now. So next, you're going to be doing extraocular muscles. So this part is where you do the 6 cardinal fields of gaze. So obviously, you start in the middle, and you're going laterally, and you're looking for nystagmus in the eyes, which is the bouncing, and you're going to do your X. Okay. And then lastly, you're going to go up, vertical, and you're looking for lid lag at this point, okay? And then the next part that we're going to talk about is the corneal light reflex. You can dim the light if you want to during this point, but the easiest way to do it is just go ahead and shine a light at the patient's eyes, and you're observing the bounce back of light, and it should be equal. There shouldn't be any imbalance in the bounce back of light. After that, what you would verbalize is if there was an imbalance present, you would go ahead and have something to cover the patient's eye. And you say, okay, I just want you to focus on my finger. You cover one of their eyes. This is called the cover-uncover test. And then you move it, and you look for any movement or non-movement of the eyes. Now remember, this is only if there's a imbalance in the corneal light reflex. And this is both for paralytic and non-paralytic strabismus. Okay? So after that, the last part of it is going to be your actual ophthalmoscopic exam.